for you so you can follow along. All right. So today we're going to be talking about advances in monitoring cerebral blood flow, and we're going to be introducing the Seaflow Regional Cerebral Blood Flow Monitoring today. And our objectives are to review the current landscape of brain blood flow measurement and to describe a new technology that's arrived on the scene that we're bringing in called UTLight, or ultrasound tag light flowmetry. We'll be differentiating brain blood flow from brain oxygenation, and you'll learn how UTLight is posed, we believe, to alter patterns of patient care. We want to gain insights into the clinical management of your patients, and during this talk we'll review quite a bit of information, but by the end hopefully you have a new view of things, and we'll leave some time open for questions at the end. So let's talk about existing methods of cerebral blood flow measurement. Today we have a variety of different ways that we can measure cerebral blood flow, and we'll just go through this quickly. Laser Doppler, perfusion monitoring, and CT xenon. CT perfusion, MR perfusion, and transcranial Doppler. We also use jugular bulb catheterization, Lycox and hummingbird monitors, digital parenchymography, electroencephalography, and then there's the good old-fashioned neurological examination. And we're talking about ultrasound tag light. So laser Doppler detects the flow of particles such as corpuscles through tissue, and it generates a velocity profile for us to study. It is an invasive monitor, and it is very position sensitive, so it's not particularly conducive to ongoing monitoring in our patients. Bowman perfusion monitor by Hemodex measures flow in an absolute value of milliliters per 100 grams per minute. It is an invasive monitor, however, and it does require some calibration at times. So again, as a practical monitor, it may not always be suitable for all circumstances. CT perfusion measures the flow of contrast through the brain. It gives us a snapshot. It is not a true monitor. It can be technically challenging. It does expose the patient to radiation and contrast dye as well. Xenon flow perfusion actually is getting a little harder to do these days. Xenon is harder to obtain. It does give us a snapshot in time. Again, it's not a monitor. It's technically challenging, and even though it's considered a gold standard, unfortunately does expose the patient to radiation. Magnetic resonance perfusion is a bit newer on the scene. It measures flow in the brain with MRI. Again, though, it's a snapshot. It's not a monitor, and it is technically challenging. And it also brings online the issue of exposing a patient to a magnetic field. Transcranial Doppler is a standard that measures blood flow velocity. It can be used as a monitor. It technically is very challenging. For those of you who do TCD, you'll know what I'm talking about. There are safety issues involved with power as well, and there at times can be systematic utilization challenges in terms of making sure that you have the right technicians on board, etc. Jugular bulb catheterization measures oxygen extraction. It is a true monitor. It is technically challenging, and it is invasive. And at the end of the day, is not really a flow monitor as much as an oxygenation monitor. With the hummingbird ICP and brain tissue oxygen monitor, we can measure brain oxygen. It's technically challenging. It is invasive, as is the Lycox brain oxygen monitor as well. Both of these, by the way, do measure brain tissue oxygenation, not flow. So even though they're true monitors, they're technically challenging and invasive. They may not necessarily give us what we're looking for. Digital angiographic parenchymography as well as one way of looking at the microvasculature. It measures capillary perfusion simply by giving us a qualitative snapshot of the brain. It is also technically challenging and also is invasive, requiring contrast. Electroencephalography is a monitor. It measures electrical function, however, not flow. So it's using electrical function as a surrogate for flow, and it too is technically challenging. Even though it's not invasive, it does bring to bear issues of systemic utilization challenges. So do you have a tech available, etc. after hours? It can be challenging. The neurological examination is non-invasive usually, measures clinical function. It is not a continuous monitor, and it is technically challenging as well. It is very intuitive, it is not precise necessarily, and it is prone to bias. So that leaves us with ultrasound tag light, which is what we're talking about today. Ultrasound tag light measures microvascular flow, and it is a true monitor. It is actually technically simple. It is non-invasive. It is portable. And when compared with other modalities, we believe actually may set a new standard in terms of measuring cerebral blood flow. We at Ornim have developed the only FDA-cleared device that is multimodal, non-invasive, continuous, that gives real-time bedside monitoring of tissue blood flow. It is also used in muscle tissue as well. We're focused today on microvascular brain blood flow. Monitoring can be done in different locations for different conditions, and we believe that this monitoring is going to change the way that we intervene. It ought to guide us into interventions and therapy targeted at the reduction of cerebral complications for tissue protection or salvation. So we think that there are primary cerebral pathologies that we may be able to improve our care on, and non-cerebral pathologies that indirectly affect brain blood flow that we can actually improve upon as well. So let's talk a little bit about the basis of UTLight and flowmetry and how it works. In ultrasound tag light, we have two objectives. One is to establish a certain depth of measurement in the brain, and number two is to establish the actual detection of flow. So when we're looking at flow with flowmetries, we're really using two different modalities that are combined into one. We're using near-infrared laser light, and we're also using Doppler ultrasound. So light and sound are combining to give us what we call the acousto-optic effect. Now the light source is a highly coherent laser. We are shining this laser through the scalp in the near-infrared spectrum. So this is close to the infrared spectrum. It is still visible light, so it's a red laser. The Seaflow device, which we're going to talk about, uses a wavelength between 780 and 830 nanometers. The sound source is ultrasound, and as many of you know, this is at a pitch at a frequency that is higher than what can be perceived by the human ear. The Seaflow device uses a 1 megahertz sound frequency. And you can see here that ultrasound is somewhere between medical therapy and medical diagnostic frequencies. So let's talk a little bit about the laser that we're using here. When the laser enters the scalp, it goes through as a highly coherent beam. It passes through the tissue underneath the scalp, which includes the skull, cerebral spinal fluid, peel structures, and the cortex itself. When it exits, it comes out of the scalp as a speckled pattern of light. It has lost its coherence. This speckle pattern is fairly predictable. Statistically speaking, we have a rough idea of what this speckle should look like in terms of the size and the frequency of distribution of speckles. So we know that as light passes through the underlying tissues, there are some photons that get back to our sensor earlier than others. When light takes a fairly short path through the scalp and the skull, it arrives back at the sensor earlier than those photons that arrive after traveling through the cortex itself. And we can actually generate a time-of-flight distribution curve, as you see in this picture here, that discriminates between photons that arrive back at our sensor earlier rather than later. These speckle sizes should be fairly uniform when there's no underlying bulk flow through that underlying tissue. And we can see that we can actually measure those photons in different fashion. So we talk about a depth resolved absorption change from multiple distance measurements, and we can actually integrate a curve here. And not to get too far into the definitions and the description, but ultimately this path that is defined by photons appears almost as a banana, if you will. It's a three-dimensional volume of tissue that is defined by the path of photons. Now what we do in our devices is we actually tag photons with ultrasound, and this helps us to discriminate even better between different layers of tissue. Ultrasound at 1 megahertz pulses travels through the subcutaneous tissues, through the skull and the brain, and it knocks some photons out of phase on a periodic basis. We can collect the light at the sensor on the back end and distinguish between light that has been in phase and light that has been knocked out of phase by ultrasound, and construct a curve. As you see in this particular curve, we're representing light that has arrived back at the sensor at a particular depth that is deep enough to represent light that has gone through the cerebral cortex into the territory of the gray-white junction where microvasculature lives. So light that passes through the ultrasound zone and is tagged or phase shifted is differentiated from regular light, and this essentially improves our signal-to-noise ratio so that we can make the most out of our technology. And what this allows us to do is, as the next step then, is to evaluate when blood is flowing through the microvasculature. If you see in the center image here, the distribution of speckles from the laser is fairly narrow. There's a high amplitude and a relatively narrow base. So in static tissues, the distribution of speckle sizes is fairly uniform. This changes when blood starts to flow through tissue. Blood flowing through the cortex takes photons out of plane. It also disturbs the photons that are arriving back at our sensor even more so that we get a broader distribution of speckle sizes. This is represented in the curve on the right. The speckle spectrum you see here is with a high flow situation. So the peak amplitude drops, the base widens. So essentially, more flow means a broader, flatter curve, which is represented as what we call the cerebral flow index. The cerebral flow index is our way of representing flow. So UTLight technology allows for the selection of the portion of the collected light targeting a particular volume of interest, which in this case is brain cortex and subcortex. And you see here the relative change in the speckle spectrum we track over time as the cerebral flow index is something that is measurable, is a qualitative measure, and we can actually track after establishing a baseline in our patients. So this is an important monitoring trend. And it's a very key point. Cerebral flow index is a relative trend. It is not absolute, but it can be differentiated at onset between patients and even between sessions. The critical issue here is following the trend is very important. Analyzing the patient's clinical scenario and then correlating trends to clinical changes. Moving forward, let's differentiate cerebral blood flow from cerebral oxygenation. It's important to make the point here that perfusion is a product of flow and oxygenation. I think there's a bit of confusion in the industry right now, and these terms are sometimes used interchangeably, but oxygenation does not necessarily equate to perfusion. In fact, flow itself is a very different quantity from oxygen saturation. And we believe that oximetry measurements alone are not sufficient to understand tissue perfusion. Glucose and brain perfusion are very important to understand. And the truth is that perfusion itself, independent of oxygenation, is important to deliver an adequate amount of glucose to the brain. Conversely, oximetry is influenced by a variety of different variables. There are 8 or 9 different variables that we believe influence oximetry, including metabolic rate, pH, and temperature. And blood flow and oxygen saturation do not always move in lockstep with each other, and they do not always move in the same direction. You can think of a septic patient as a good example of a case where oxygen saturations may drop while flow actually increases. The difference between saturation and blood flow is that flow is a very direct and actionable parameter. So if you go back to Poiseux's law and you think about ideal conditions and what kind of factors influence flow, such as pressure, radius, viscosity, and tube length, the ideal determinants of flow are a higher pressure, a larger radius, a lower viscosity, and a shorter tube length. Remember that metabolism drives flow, and metabolism of the brain depends upon glucose delivery. Metabolism also does yield higher oxygen needs, and we can distill down flow to essentially changes in pressure over changes in resistance. I'm sure some of this is familiar to many of you, but the ultimate take-home message here is that there are simple concepts that we can distill down when we're thinking about flow as opposed to oxygenation. So events that could be expected to decrease cerebral flow index might include decreased perfusion pressure and increased cerebral vascular resistance. Decreased perfusion pressure is fairly straightforward. This is either the result of arterial insufficiency or obstruction, or venous outflow resistance or obstruction. So again, remember that perfusion equals flow times oxygenation. Let's review clinical applications then, in which we think that flow measurement is important. Stroke, both ischemic and hemorrhagic stroke, may benefit from this. Subarachnoid hemorrhage, and in particular the late consequence of cerebral vasospasm, traumatic brain injury. cerebral edema and its consequences, and coronary artery bypass grafting. This may also include open heart and on-pump bypass, valve replacement surgery, are all conditions that may benefit from a better understanding of cerebral blood flow. Carotid endarterectomy as well may be very well open and ripe, and we've had some very favorable clinical data in this realm. Percutaneous cerebral vascular interventions are also appearing to be benefited by cerebral blood flow monitoring. We think that there may be a role in cardiopulmonary resuscitation efficacy in measuring how well your cardiac compressions are registering in terms of cerebral blood flow. You may contemplate also the effect of acute cardiac arrest with return of spontaneous circulation. Over the last decade, we've seen quite a significant improvement in outcomes in patients who undergo systemic temperature modulation in the acute care setting. We think that there may be a role for cerebral blood flow monitoring in this role as well. Consider the patient with hypoxic ischemic encephalopathy. Are we actually monitoring brain blood flow adequately in this patient population? I would say no. You might even consider other conditions such as sleep apnea and hypopnea, potentially even headache. And then we're also looking at barotrauma, altitude sickness, and diving sickness, and possibly even the effects of outer space on cerebral blood flow. There's some evidence that suspended animation in cases post-massive trauma may actually be viable, and so we're potentially looking at this as well. And the fact is that probably any surgery with the potential for hemodynamic derangement that leads to cerebral hypoperfusion may benefit from better monitoring and surveillance of cerebral blood flow. Thinking of specific scenarios and interventions then, in cases where we have decreased perfusion pressure, you can think of hypotension and shock, arterial thromboembolism, vascular stenosis and occlusion, as you mentioned, cardiac arrest and decompression and air embolism. There are specific roles and interventions in each case. So when a patient is hypotensive and in shock, we like to try to normalize blood pressure. In the case of arterial thromboembolism, lysis and embolectomy may be in order. In the case of vascular stenosis occlusion, revascularization may be in order. In the case of cardiac arrest, CPR. And of course, in the case of decompression and air embolism, barotherapy may be as well a modality that we bring on board. In cases where we have increased cerebral vascular resistance, so this is our denominator, we may be looking at intervening through vasoactive therapy for patients who are suffering from vasospasm. This may include also cerebral vasospastic syndrome and migraine. Patients with venous thrombosis may benefit from lysis and embolectomy. In cases of cerebral edema, you may think of cerebral edema countermeasures. When there's local mass and tumor, decompression of steroids may be in order. And in cases where hydrocephalus is at play, ventricular decompression may also lower cerebral vascular resistance. Be curious to know of the participants that are online if you think that these are clinical conditions that you might benefit from measuring cerebral blood flow. In terms of our product status right now for the Seaflow monitor that we're bringing to market, we've gone through preclinical validation and safety monitoring. We've done studies on clinical validation and safety in the clinical environment, and we're currently entertaining several clinical trials at this time and moving into clinical production. So in conclusion, after our brief summary here, we're very happy to announce that we're bringing Seaflow to market right now, and we're providing the market's first regional cerebral blood flow measurement tool. It's now available continuously, non-invasively, at the bedside, and in real time. And the question is, are we setting a new standard for the market? So this is a brief overview of what we're bringing to the market, and very curious about your experience with cerebral blood flow monitoring. And at this time, I'm going to open up the floor to questions. If anybody would like to come in and ask questions, you have your text region here where you can enter text and chime in. So we're not getting any questions coming through. I think I'll like to put out some polls for those of you who are attending. Please go ahead and take a look at your first poll if you don't mind. I'd be very curious to know, of those of you who are present here, how many of you are neurointensivists, neuroanesthesiologists, and neurosurgeons? How many of you perform neuroendovascular surgery or other? And just as a quick review on your GoToWebinar control panel, you should be able to enter questions off to your right-hand side. Okay, first question that's coming in right now. What is the main difference with the, quote, competition, such as Somanetics, etc., and CAS? Well, thank you very much, Ricardo, for that question. Truth is, we're really, at this time, not considering that we have competition. So the existing companies that advertise the measurement of oximetry are focused on the measurement of oxygen saturation of brain blood. They're looking at mixed blood flow, or mixed blood oxygenation, I should say, and not focused on flow at all. So the truth is, at this time, there's no other company that actually is looking at non-invasive cerebral blood flow on the market. Great question. So what is the price point with this monitor? So we have a variety of different ways that we actually are able to price this for folks out there. The device is actually right now being made available to institutions for a free 1-month trial. If you like the device and care to purchase it, it's a $30,000 cost. We have disposable pads that actually allow the probes for the monitor to adhere to the scalp, and those are $125 per pad for a box of 20. And we have a variety of different ways of bringing that on board right now so that we can make it very easy for you. We're very interested in making this something that is easy and comfortable for you to bring into your clinical environment for you to study with your patients. All right, we've got a great question here. If you're monitoring a patient and are forced to disconnect, how closely can you compare the two sessions to each other? That's Dr. Gomez asking this question. This is probably one of the challenges that we're dealing with right now, since we're looking at a relative index. We can't tell you reliably that if we disconnect the monitor and put it back on, that you're necessarily going to get the exact same index. So from a certain point of view, this is a bit of a limitation. I can tell you that our physicists are working on developing an absolute that we hope to roll out for a future product. But even with that, I think that from a certain point of view, there's definitely a benefit of looking at a relative index over time. So taking into account the clinical scenario, if we have a patient, for example, who comes in with acute ischemic stroke, and we're developing protocols along these lines. If the patient comes in with an acute stroke and is given a lytic therapy and doesn't show an improvement in flow, in that clinical scenario, you can see right away that you're not necessarily getting the expected result and can escalate your therapy. If a patient is undergoing a procedure that should restore flow and you're not getting changes, that may change your therapy as well. So really right now we're looking at the relative index change over time. We've seen really interesting results in patients who have had carotid endarterectomy, for example, and undergone cross-clamping. We'll discuss this in more detail at a future webinar and actually show you examples of how cerebral flow index changes during cross-clamping or in particular conditions such as middle cerebral artery occlusions, for example. Okay, good. Let's go ahead and ask our next question here while we're waiting for more questions to roll in. What is your current approach to monitoring brain injury today? Do you actively incorporate multimodal monitoring into your practice? Do you sometimes use it? Are you interested but not using it right now? Is it something that you're unable to monitor, or do you just not see any benefit? We'll take about a minute to get this answered here. Okay, good. So it looks like about half of you actively incorporate multimodal monitoring into your practice or sometimes use multimodal monitoring. Looks like we've got a very interesting group here.